So, dear Dusan, thank you very much for the invitation to this wonderful meeting. Ladies and gentlemen, colleagues, I will follow up what Professor Kim already started, and it will be the central vestibular vertigo. So I hope that I can tell you a little more or new things also on this topic, even if there's some overlap with what we have heard before. So first, on the anatomy, what do we talk about if we talk about central vestibular lesions? So obviously we talk mostly about the lesions in the brainstem and in the cerebellum. And why is it? It is because most of the vestibular projections actually run through the brainstem. And if you take the vestibular nuclei, you have these ascending projections to the oculomotor systems, you have the descending projections to the spinal cord, and you have a lot of projections to the cerebellum. And searching for vestibular deficits also means to make a real good oculomotor exam, because both of the systems are closely interacting by the vestibular-ocular connections. So if you want to take the frequency of central vestibular disorders in about 22,000 patients we followed over the last few years, it comes that it is the third most frequent diagnosis of all patients presenting with vertigo or dizziness. And vestibular migraine, which may be thought of a specific type of central vestibular disorder, is the fourth most frequent. So it's really important to deal with these kind of patients. So one of the major problems on dealing with central vestibular lesions actually is that the history may be very different. So as you heard, it can occur that the central vestibular lesions present with an isolated vertigo and dizziness syndrome without any other symptoms of brainstem or cerebellar signs. But it can also be that it presents as recurrent attacks lasting for some minutes, 2 hours and days. And of course, we have some entities where we have chronic dysfunction, which makes symptoms for the patients. So problem is that pure history does not tell us very much about the etiology, and it does not securely differentiate from peripheral vestibular disorders. So let me go through all of these three types. So that's the one you heard already. It's an acute onset of vertigo sensation with a subjective oscillopia. And as you heard, it may well be that you have a lesion which is in the fascicular and root entrance zone of the vestibular nerve, like depicted here, or even in another case. Or it may well be that it is in the dorsolateral medulla, and it makes some isolated vertigo sensation. So that's our main problem, how to differentiate these cases as opposed to peripheral vestibular lesions. So I'll show you another video where you can see some of the very typical signs of a dorsolateral medullary lesion. So first of all, you will recognize that there is some skew deviation, so some vertical deviation of the eyes. And you see some spontaneous nystagmus, which gets more in the right gaze position. And in the left gaze position, you see that the direction of the nystagmus changes, which is a central criterion. You also see nystagmus under the Frenzel's googles. You see the vertical deviation, and you may also see the anisochoric pupils, which is then due to Horner syndrome. So if you see one patient like this, I think you're very clear that this is a central lesion. You have a bunch of central oculomotor signs. You see here in the cover test also that you get a vertical fixation which comes up from down from the left eye and from up from the right. So this is the criterion how you would clinically diagnose a skew deviation. You see, the right eye comes from up, the left from down. So that's what shows you the vertical divergence of the eyes, and this is a very sensitive clinical sign. So still, if you want to examine her postural control, you see that there is some kind of postural imbalance, which even increases on the standing position. So I don't think that anybody is in doubt that this is a central lesion. But yes, it can be more subtle, and so we have to run through the different signs we can pick up to identify a central vestibular lesion. So first of all, up there you see the ptosis and the meiosis of the eye, which is a Horner's syndrome, and it's in central vestibular lesions because the central sympathetic pathways are lesioned. They run through the tegmentum of the brainstem and cross the vestibular nuclei on the dorsal lateral medullar side. This obviously is the skew deviation, which you can see just in primary position, or you can examine by just covering the eyes alternatively. Down there you will see the typical sign of the nystagmus. You see there is a right beating nystagmus with some rotatory component. So it does not help much. It can be also peripheral. But of course, it's an important sign which shows you also the vestibular imbalance between sides. If you follow the end position of the eyes, you'll see that there is a right beating gaze-evoked nystagmus, that there is some kind of gaze-evoked nystagmus also while looking up. And most importantly, there is a left-sided gaze-evoked nystagmus. So this is what makes hints the change of directions of your gaze-evoked nystagmus. This is due to a lesion of the so-called nucleus prepositus hypoglossy. So this is the center in the brainstem which makes gaze holding, and it's quite near to the vestibular nucleus. So if the vestibular nucleus is lesioned, you also get a lesion to these MPH, and from that you get these gaze-holding problems, which clinically turns out to be a gaze-evoked nystagmus. This is never the case in a peripheral vestibular lesion because we have Hering's and Listing's law. It never changed direction. And some subtle also symptom which you may pick up is that if you look on the saccades, you will easily see that the saccades are somewhat hypometric to the right and hypermetric to the left. So this is also a very typical sign of Wallenberg syndrome, that you have saccadic dysmetria. So last but not least, you can also, of course, pick up some deficiency to detect verticality. There are several modes of doing this. This is one easy. You can just let the patient make a vertical bar stand vertical. Another obviously would be to subjective visual vertical measurements, and there's an easy way to do that. You can build a bucket, you can look it up, so it's quite easy. And so you see there is a lot of symptoms and clinical signs which you can pick up. So this is Wallenberg syndrome. What do we do with Wallenberg's? I fully agree with Professor Kim. This is an emergency condition. You immediately have to transfer the patient to the hospital. Why is it the case? First of all, a Wallenberg syndrome may be the earliest sign of a progressive basilar thrombosis, and this is then a life-threatening condition. Secondly, patients with Wallenberg syndrome do have severe autonomic failure. So it may be that they get asystolic if you want to create a vagal nerve stimulation. And of course, often they also have dysphagia, and so this may make up a secondary problem. I fully agree that it is very important not only to do the standard MRIs or CT scans, but to depict the vessels, because most of the time you will detect some stenosis of the distal vertebral artery system or the pica. And our opinion is if the patient comes within the first 4.5 hours after onset of symptoms, you may also think about doing IV thrombolysis. And of course, you have to deal it similarly than other strokes, so you have to give aspirin either, or in the turn, some anticoagulation if it's due to cardiac embolism. So just, again, a summary of the most valuable sign to differentiate pseudoneuritis from neuritis or Wallenberg syndrome from peripheral lesions. So I think most recognized is the hints, and that you heard already, but you cannot overemphasize. It's very important to differentiate pica infarct from peripheral lesions. Maybe one additional thing, so we trust a lot on the subjective visual vertical because it's a very sensitive sign. In case you have a deviation of the subjective visual vertical, you know that there is some asymmetry between sides, but of course it does not differentiate peripheral and central. It's only a detective test to see that there is any kind of asymmetric lesion in your vestibular pathways. Okay, so that's somewhat a repetition we already heard, but of course it may be even more complicated because we are talking about not only patients who present with vertigo, but it may be that they present with some dizziness or oscillopia or double vision, and it may be even more complicated to diagnose these patients. So even if it's a little complicated, I will run fastly through the different oculomotor centers of the brainstem because it helps a lot for your topographic diagnosis. Actually, the oculomotor centers in the brainstem are organized in this way that in the brainstem tegmentum we have several centers which make several kinds of oculomotor movements. So first of all, up here in the mesencephalic tegmentum, you have two nuclei. This is the REMLF, the rostral interstitial nucleus of the MLF, and the INC, which is the interstitial nucleus of Cajal. And both of them make vertical eye movements. The one, the saccadic eye movements, the other, the gaze holding to the vertical side. So if you get a lesion up there, you will get saccadic paresis, or you will get gaze-evoked nystagmus in the vertical direction as an isolated sign of a midbrain infarction. Posterior commissure, I will talk a little bit about it, makes a very distinct clinical picture. And down here in the pons, we have a center called PPRF, where we generate the horizontal saccades. So it's like generating saccadic movements to the right and the left. So if you have a lesion here, you will present with an isolated gaze palsy ipsilaterally to the lesion. And the nucleus prepositus hypoglossy we talked about is regularly involved in medullary infarctions. So it's not only that you can pick up your vestibular signs, but you can also pick up some distinct oculomotor signs. So I will show you some cases here of very distinct lesions, starting here with the mesencephalic brainstem lesion. Just take a look what you see. Of course, the patient should do vertical saccadic movements, and it's very clear that they are severely slowed. So it's a slowing of your vertical saccades, and there's even some gaze palsy up and down. So this patient actually had an isolated midbrain lesion affecting these oculomotor centers of the midbrain. And sometimes these patients present with some unspecific dizziness, or they say they have problems reading or picking up things while doing saccadic movements. If we go a little bit further to the posterior commissure, which is a communication of both midbrain signs, we also get a very typical clinical picture here. Hope this starts. Otherwise, we'll start with this. This is another case where you get some gaze-evoked nystagmus only in the vertical position, and looking down, some gaze-evoked nystagmus also while looking down. So this is an example of a lesion of the so-called INC, because your gaze-holding system won't work well while having a lesion quite here in the INC. So probably this won't work, so we'll start with another case. just look at this guy. So he's young, he presented with some dizziness and oscillopia to our outpatient clinic. And of course what you see is some beating of the eyes in the upward position, right? So this is phenomenologically called an upbeat nystagmus. And you see it does not depend on the direction, but it is in the primary position, it's on fixation, and it can even get more while looking to the lateral position or while looking up. And these patients regularly do have lesions in the so-called central tegmental tract, so midline of the pons or mesencephalon in the tegmentum. So this can also be a very isolated presentation of subjective dizziness. So see, it's really worth looking quite closely to the eyes and try to examine all different kinds of oculomotor functions, not only nystagmus in the primary position or within Francis Googles, but try also to examine the gaze-evoked nystagmus, the gaze-holding function, and the saccadic system. It will contribute a lot to your topographic diagnosis of brainstem lesions. So this is another example which then shows you some lesion of these horizontal saccadic systems which are in the pons. And you see the young girl, she should do some saccadic movements in the horizontal position. And of course, they are severely slowed, and even it looks like there is some horizontal gaze palsy more to the left than to the right. So this is also an example of a very pinpointed lesion of the pons. So that's for the acute lesions. Of course, I did not cover what Professor Kim told about the cerebellum. This is a wide field of also differential diagnosis. I stuck a little bit more to the brainstem. So the recurrent attacks of vertigo, can they be a central sign? So if you heard to Professor Kim, yes, definitely, it can be. But we have some differential diagnosis. So just here to the young guy here, he came to the outpatient's clinic, and you will hear some history he is telling you.
Leopold, why have you come to us today?
Because I have dizziness.
Do things spin around, or is it more like rocking back and forth as in a boat?
More like spinning around.
It spins, and when it spins, how long does it spin? Hours or minutes?
Minutes.
How often does that happen? Once a month, once a week, once every 2 to 3 days?
Every 2 days.
And when you're dizzy, have you noticed anything else in addition?
Headaches and nausea.
And what do you do when you're really dizzy? How do you act?
Then I'm quieter.
Then you're quieter. Thanks.
Okay, so young guy, is it stroke? No, I think this is not stroke because, you know, he's quite young. He's had these recurrent attacks of vertigo, and he's quite nicely saying how it works. So it's vertiginous, it takes minutes to hours, then he gets headaches, and he has some feeling that he may rest because then symptoms will get better. So what it is it Meniere's disease? Is it something else? No, that's vestibular migraine, right? And so vestibular migraine is also one of the central causes of recurrent vertigo. Of course, it can also involve the inner ear, but it's a very important differential diagnosis because it's the most frequent recurrent vertigo which we are actually dealing with. So it's a very new entity. If we go back 20 years, nobody would have talked about vestibular migraine at all. The diagnosis was not existent. So then people started to notice that it is a quite common symptom before headaches, that people get dizzy or vertiginous, and it takes for some minutes to hours. So then the diagnosis of vestibular migraine was established, and the concept was it may be an aura-like symptom similar to visual symptoms or somatosensory symptoms. But still we struggle a little bit how to actually fix the diagnosis because we don't have a very clear and a measurable parameter to do so. So it's a chameleon, it's complicated. You know, the vestibular migraine has been defined by Lampert and others as 5 criteria or 4 criteria. And of course, it's rather unspecific. What you have to have actually is that you should have at least 5 episodes with vestibular symptoms, and it should last from 5 to up to 3 days. And what is most helpful, obviously, is that you have a history of migraine, or you may have, and this is very important, 1 or more migraine features at least in 50% of the vestibular episodes. So that's very important, that you report first the vestibular symptoms, and then afterwards you get indication of migrainous headaches. So it can be headache, it can be photo or phonophobia, it can be visual auras. So it's adjusted to the International Classification of Headache Disorders. And yes, point D is always what is written. You have no better explanation for it. And that's at times a little complicated because you may have also other clinical signs. And what we actually classified is in a probable or possible vestibular migraine. And most of the clinical cases qualify for the probable vestibular migraine, where we have 5 attacks and only 1 of the 2 criteria, either of a headache's history or signs of headaches with the vestibular attack. So what do we do about it? So there are some problems which we actually face. First of all, there is not a strict distinction of vestibular migraine and some cases of Meniere's disease. And I have to say that there are overlapping symptoms which qualify either for the Meniere's or the vestibular migraine classification. And it may well be that there is a common pathophysiological pathway which causes both symptoms. It can also be accompanied by some inner ear fullness symptoms, some fluctuating hearing. So that's a problem. We don't have a strict distinction to Meniere's disease in some cases, and there may be an overlap symptom with Meniere's disease. What do we do for treatment? I have to say that almost every drug agent we use in everyday's practice is not based on clinical studies. We do not have controlled clinical studies on these entities. And the same is true also for the vestibular migraine. So what is our suggestion is just to adapt treatments from the regular migraine studies. So in the acute phase of attacks, you may just treat this with some symptomatic approach of giving aspirin or non-steroidal drugs, or if the emesis and vomiting is predominant, you may also give antiemetics. Of course, this does not change much on the course of the attack, it just reduces the symptoms. And we have no agent to prevent the attack from going yet, because if once it goes, you only have to treat the symptoms. It may be that in the future, and this is some new data, we will have new agents, for example, the 4-aminopyridine, to decrease symptoms, but that's not yet the standard. So I would just suggest to give painkillers and antiemetics in the attack. As concerns prophylactic treatment, still we do not have any clear study to prove. But I have to say that the clinical experience says that the beta blockers may work quite well. There is an ongoing placebo-controlled trial which is actually run in Munich, and we are halfway finishing. So hopefully we get data soon to also prove that this works. Alternatives may be topiramate or valproic acid, which we similarly use for treating the classical migraine. But this is my subjective and maybe the expert opinion. If we look at a Cochrane-based review, you know, the Cochrane reviews are always very conservative. And the actual opinion on this, and it's been written only a few months ago, is that there is no evidence for any treatment prophylactically in vestibular migraine, that it, based on the current status of studies, cannot be really administered because there may be some even more severe side effects. So that's the current official opinion. But of course, we have to deal with these patients. We have to offer these patients some treatments. So I hope maybe in the next year you could stand here and report on some positive results of the metoprolol study, which is halfway done. So actually, this would be my first choice. In children, it's a little different. You know that the paroxysmal episodes of vertigo in the children are a migraine mimic, which is most frequent in children. So if you have children with recurrent attacks of vertigo, always think about a vestibular migraine as a potential etiology. In these children, it may work that you just give them some magnesium. It works quite well if it's not so severe. And you can also give them some flunarizine. It also works. And in terms, you can give them also a little small dosage of beta blockers. But you have to be even more careful in children, no doubt. So that's the opinion on the vestibular migraine. We wait for further studies. So just listen to this guy. He also has recurrent attacks of vertigo.
5 years ago, you came to our hospital for the first time. What were the symptoms you had during those days?
I had around 4 or 5 attacks a day, and symptoms were like I lost my balance. I lost sometimes completely my coordination of movements, etc., and I couldn't walk properly and things like this.
How long did the attacks last?
So on the average, an hour, more or less.
An hour.
1 to 2 hours.
Were there any factors that could induce these attacks or make them worse?
Yes, definitely. This is what I found out myself. It was, first of all, drinking alcohol was very bad. Stress, psychological stress, and doing sports, efforts like this, I completely failed doing it.
Thank you very much.
Welcome.
Okay, so this is a history which you may hear every day, or it's some more complicated story. So he also reports some recurrent attacks of vertigo, right? 3 or 4 of them. He says it's propagated a little bit by exercises or drinking alcohol, or if it's stressed. Sometimes he had some pain in the occipital neck region. So would that qualify for a vestibular migraine, or do you think it could be something else? Hard to say, right? So if we just applied the official criteria, he's not had 5 attacks, we don't have a clear history of migraine, so maybe we are not so convinced that this is a vestibular migraine. Actually, it is not, because if you ask somewhat more in his family history, similar attacks have been present also in his father, and he has a brother who has similar attacks. And therefore, this diagnosis is a rare picture of so-called episodic ataxia of type 2. And why do I give this here as a follow-up of vestibular migraine? Because both of them do have overlapping symptoms, and it may be hard to differentiate in certain cases. So what are the clear criteria for the episodic ataxia type 2? You will have paroxysmal attacks of ataxia, and they will also last for minutes to hours. Most importantly, if you examine the patient, you will get some more severe than expected central oculomotor signs. It can be some saccadic smooth pursuit, it can be some gaze-evoked nystagmus, and it readily is some downbeat nystagmus which you can pick up between the attacks. One of the clues to diagnosis is that you should ask the patient if these attacks can be propagated by certain kinds of exercises, sports, or alcohol. And of course, the starting of the symptoms often is in the early childhood or youth age, so it's a little earlier than vestibular migraine starts regularly. And the course is slowly progressive, so you may also pick up some signs of cerebellar dysfunction between the attacks. And of course, the family history may be positive in these patients. So what is the problem? The problem is that these patients carry a mutation of the so-called PQ calcium channel. And PQ comes from Purkinje cells and granular cells, though this is a ion channel which is expressed in the cerebellum. And the Purkinje cells may be dysfunctional. So how could we treat these patients? There is a very nice approach to treat them, actually. So this is the 4-aminopyridine. 4-aminopyridine actually is a drug which changes the excitability of Purkinje cells by binding to a channel of the Purkinje cells. And this has been a study carried out by Michael Stoop in 2011, where he could nicely show that 4-aminopyridine decreases the frequency attacks by almost bringing them down to 0, and this is significantly more than if you just take a placebo. And if you bring it in and fade it out, the attacks will come back. So it's a quite established principle to treat these attacks in these patients, and you should not overdo these rare cases, because otherwise you will not have any other chance to treat them properly. And this is how it works. So the actual thought about it is that it increases the frequency and regularity of the firing of the Purkinje cells, which is deficient in these patients. And by that, it may improve the cerebellar symptoms, and it may bring the threshold for the attacks a little bit up. So that's a rare differential diagnosis. Be careful. Also in vestibular migraine, you will pick up some subtle signs of central cerebellar things. So if you have only a little saccadic gaze following or a little bit of gaze-evoked nystagmus, it could well be still a migraine. But if you have it more severely, or if you have downbeat nystagmus on top, if you have a positive familial history, then it is not readily a vestibular migraine, but you should think of some episodic ataxia, which can be the case. Okay, so this has been the part on the central vestibular system, and we already crossed the border to the cerebellum, because, you know, there is no way of just dissecting things. It's all one system.